Good morning, one and all. This is myself, Dr. Lynette Anthony. I'll be talking on the causes, management, and visual outcome in patients with atypical optic neuritis. Typical optic neuritis is characterized by acute painful loss of vision which has a good visual recovery, and it is often associated with multiple sclerosis. Atypical optic neuritis is less common, has poorer visual outcome, and is associated with other systemic disorders. So it is important to consider alternative etiologies in such cases, investigate accordingly, and institute more specific therapies. The aim of the study which we conducted was to describe the causes, management, and visual outcome of patients presenting with atypical optic neuritis. A retrospective analysis of patients presented to our center with atypical features of optic neuritis between January 2015 and March 2018 was conducted. The atypical signs and symptoms of optic neuritis which we looked for were age more than 50 years or less than 12 years of age. There was sudden visual loss, there was progressive visual loss for more than 2 weeks, or absence of recovery even after 3 weeks of onset. There was severe bilateral visual loss to no perception of light. There was no pain, clinical systemic symptoms suggestive of other diseases other than multiple sclerosis, severe optic disc edema or optic disc or peripapillary hemorrhages, marked uveitis or retinal periphlebitis, optic atrophy without history of optic neuritis or multiple sclerosis, deterioration even after the withdrawal of the steroids. 11 patients with an average age of 34 years of age was included in the study. 3 were males and 8 were females out of the total. The causes which we came to a conclusion were the post-infectious cases were 3, which were either viral or cat scratch disease. 2 were under the cause of neuromyelitis optica. The other causes which had 1 patient each was ITP, SLE, pancytopenia, toxic, postpartum or idiopathic. Trial of steroids were given. 6 patients responded to steroids, 4 patients were steroid dependent, and 4 patients were given immunosuppressants. Patients with the post-infectious neuroretinitis were treated with a course of doxycycline as well. When we came to the visual outcomes, there was a mild loss after the treatment in 5 patients. There was a moderate loss in 2 patients and severe loss in 4 patients, out of which 2 patients had bilateral severe loss of vision. Presenting one case, a 28-year-old male presented with bilateral blurring of vision since 3 days. There was a history of fever with rash 2 weeks ago. He was treated with antibiotics and his visual complaints were resolved. The right eye vision was 6/24 and left eye was counting fingers at 1 meter. Color vision was abnormal and pupils were ill-sustained in both the eyes. Fundus showed bilateral severe disc edema, retinal edema along the infratemporal and superiotemporal arcade. He was treated with IV methylprednisolone for 3 days and doxycycline, and resolution of the disc edema and retinal edema was seen. This is the OCT showing the resolution of the retinal edema. In conclusion, I would like to say that atypical optic neuritis has a poorer visual outcome. Post-viral neuroretinitis has better prognosis. Atypical presentation should prompt high index of suspicion, and prolonged steroid therapy or immunosuppressive may be required.